So Dr. Harry Hines was a beloved SWOG member and national leader whom we honor each year with a special lecture on cancer prevention or community oncology issues. I certainly can't think of a better person to speak in his name than Dr. Otis Brawley. Dr. Brawley's official title is Chief Medical and Scientific Officer of the American Cancer Society, but we all know his real titles, Giant in Oncology and World Expert in Cancer Disparities Research. At ACS, he's responsible for promoting the goals of cancer prevention, early detection, and quality treatment through cancer research and education. He champions efforts to decrease smoking, improve diet, and provide the critical support cancer patients need. He's enhanced ACS research programs and increased advocacy capacity, as well as concentrated community cancer control efforts in areas where they will be most effective. Further, he's a key leader in the Society's work to eliminate disparities in access to quality cancer care. Today, he will talk about the new era of cancer control research. Please help me welcome Dr. Otis Brawley. Thank you so much for coming.
Thank you. I hope there's a video of that introduction. It's a real privilege to be here as I look out in the audience. I came to my first SWOG meeting 28 years ago when two people named Marge and Chuck used to run SWOG. Remember them? And actually back then, Werda McCaskill-Stevens and Leslie Ford were sitting in front to make sure I got it right. So some things just don't change. I want to say it's a real privilege to be here, and it's wonderful to be back at SWOG. I haven't been to a SWOG meeting in 18 years. I also want to say thanks to the AV guys back there. I'm a medical oncologist and epidemiologist, and I have the privilege of working for the American Cancer Society, and also I have a gig at Emory University. I'm going to talk to you about cancer control in the 21st century. In terms of employment and disclosures, I also do some work for Turner Broadcasting for CNN. My job there is to make Sanjay Gupta look good. Some time ago, they figured out if they put me on TV with him every 3 months or so, the contrast between the two of us makes him look really pretty and me look I don't know what. And then I work for the federal government in a number of things. It's actually really neat to look out in the audience and see so many old friends here. I see Dr. Maskins over there, and then all of a sudden I realized that I met Nick Vogelzang 37 years ago, and I don't know if I'm supposed to say it's been that long. I did a book a couple of years ago that did pretty well. I'm not here to hype the book at all, but I still put it in my disclosures. It is a true honor and privilege to talk about Harry Hines and to give the Harry Hines lecture. I first met Harry in 1990 when I worked in what was then called the CCOP program for Leslie. And I was a young kid running around with these medical oncologists in their 50s and 60s trying to hide the fact that I was so young. Harry was an Irishman who had come to this country and trained in hematology and oncology when hematology and oncology was a very young specialty. Many of us forget that the first medical oncology board exam was 1973. Harry got the full picture of medical oncology. It wasn't just treat, and charge for the drugs that you give, but it's also to try to prevent disease, to treat disease, that's important, but also quality of life. And perhaps it's most fitting that now when you go to Wichita, they have the Harry Hines Hospice. I kind of like the alliteration, but knowing Harry and knowing Harry's concern about quality of life and pain control and other things, I think is very appropriate. Harry was one of the first people to be interested in getting health care into the community. The CCOP program was an experiment back in the 1980s to actually see if doctors in private practice and community hospitals could actually provide care at the same level as doctors at universities. And by the 1990s, there actually were some publications of which Harry was a part, Leslie was a part, and the university docs don't like to talk about those publications. Let's just say that. But in any way, Harry helped to bring care into the community, and Harry was involved and thought about such things as financial toxicity when we just said things cost too much. The rural versus urban outcomes paper of Joe Unger is something that Harry would be very proud that SWOG was involved in. He was very much into getting care to the people, and I'm going to talk a little about that. In my job, which I've had over the last 12 years as the Chief Medical Officer of the American Cancer Society, I've been able to sit back and sort of be the baseball fan and keep score. What's going on in cancer? What are the new exciting things in treatment? What's the new and exciting in prevention? What's new and exciting in our understanding of the biology of the disease? Perhaps the most important thing is this slide. I'm an epidemiologist, so forgive me, I have to give you some number slides during the way. In 1900, for every 100,000 Americans, the age-adjusted death rate from cancer was 64 per 100,000. By 1991, that figure had grown to 215 per 100,000. We literally had almost more than a tripling of the death rate from cancer over the first 91 years of the last century. The death rate has gone down considerably since 1991. It has gone down 26% over about a quarter century. Now that 26% decline means that 2.3 million Americans did not die of cancer since the early 1990s. The fact that the death rate is going down means that Americans are not dying of cancer who would have died if it had not gone down. The unfortunate thing is the United States was the 31st country in the world to have a 25% decline in cancer mortality. Healthcare in many countries aim more at preventing disease than at treating disease, and many countries have far less disparities than we have in the United States. Compared to other countries, healthcare is very heavily focused on diagnosing and treating disease as opposed to preventing disease. Let me back away from the cancer talk and just give you an example of that. I've had the opportunity to spend a lot of time in Europe. If you have a medical student who is with an attending and they are seeing a 55-year-old person who is diagnosed with moderate hypertension, in the United States, the doctor very likely will prescribe a dose of lisinopril and say, bring the patient back in 3 weeks and let's see if the blood pressure is better. If you ask the medical student in the United States, why did the doctor prescribe lisinopril, the doctor will look at you, or the medical student will look at you strangely and say why it was to treat his high blood pressure. If you do the same thing in France, have a medical student and a attending physician and a 55-year-old with moderate hypertension that's newly diagnosed, the physician is very likely to prescribe lisinopril. If you ask the French medical student why did the doctor prescribe the lisinopril to this patient, the medical student will say it is to prevent cardiovascular disease and renal disease. The medical students in Europe are clued into preventing disease from the beginning of their career. The medical students in the United States are clued into making the diagnosis and treating disease from the beginning of their career. The thought process is actually really important and really does affect a lot of things, and we'll talk a little bit more about prevention. You see, that 25% decrease in cancer mortality that I showed you since 1991 is overwhelmingly because of prevention. The biggest preventive intervention is actually tobacco control. Actually, there's some other cancer control mechanisms that people don't think about. Frank Maskins will tell you that refrigeration actually lowered the gastric cancer death rate in the United States dramatically over the last 50 years. And that's actually true. We moved away from salted foods, nitrate preserved foods, because we got away from the ice box and we had these beautiful refrigerators. Most of the population in this room don't know what an ice box is, by the way. Frank does. The next reason beyond prevention is wise early detection. And we in this country have spent an awful lot of time and effort on stupid early detection, things that actually did not work and that sometimes have actually ignored early detection tests that actually save lives while we advocated things that did not save lives. But wise early detection is the number 2 reason for that 25% decline. And then improvements in cancer care is number 3. Now, can we quantify the possibilities? How many lives can we positively affect if we had a high-performing health system, a health system that encompassed all Americans and gave everybody the care that we should get? I can't give you that number, but I can come close. You see, my epidemiology group at the American Cancer Society, we publish these numbers every year. 1.6 million Americans will be diagnosed with cancer this year. 610,000 Americans will die from cancer this year. Well, one of the things that we actually know is the 32% of us who are college graduates have a much lower risk of cancer death than the other 68% of Americans who are not college graduates. And let's just ask the question, how many people would die if all Americans had the risk of cancer death of college-educated Americans? Now, that's a question that's irregardless of race. It's actually irregardless of income. And that just assumes that all Americans, the other 68%, get the same cancer care, be it prevention, screening, diagnosis, and treatment, that college-educated Americans get. Well, the answer is, instead of 610,000 Americans dying of cancer this year, 140,000 less would die. A quarter of all cancer deaths would go away if people got the care that we already know about. That's not a new drug developed by a drug company or a new treatment developed by SWOG. That's just giving every American what we already know that every American ought to be getting. That's one way to that's one way to quantify health disparities. Now, a brief history of health disparities. Health disparities actually started out in the 1960s and 70s when people realized that there was this thing called sickle cell anemia, and people would look at black versus white, and it was actually not called health disparities, it was called minority health, and then special populations health, and it morphed into health disparities under David Satcher as Surgeon General, and now there's a movement to start calling it health equity. More on that as we talk at the end here. Let's talk about health disparities. In 2015, the death rate from cancer in the state of Utah was 125 per 100,000. These are age adjusted to the 2000 standard. In 2015, the death rate in Kentucky was 195 per 100,000. That's a disparity. It's a disparity based on residency or state of residence. Now, we've spent a lot of time in this country focused on race and racial disparities. I want to point out that race is a socio-political category and not a scientific category. What I mean about that is racial definitions change over time. If you know someone who was born in India and they came to the United States prior to the 1950 census, if they're alive today, they've been 3 different races in their lifetime. They were actually Caucasian in 1960. And my all-time favorite is Barack Obama was a white boy in the 1970 census, and he turned black for the 1980 census. The 1970 census said that you should declare yourself to be the race that your mother considers herself to be. It was a very Judaic definition. It actually makes sense. You may not know who your father is, but you generally know who your mother is. There's black-white cancer data that's available since 1972. It came out of the National Cancer Act, and the SEER program was started at the National Cancer Institute. In the early 1990s, we got a little bit broader and started gathering data on Asian Pacific Islanders, Native Americans, Alaskan Natives, Hispanics, as well as non-Hispanic blacks and non-Hispanic whites. And oh, by the way, I should tell you that Native Hawaiians, I saw my Hawaiian friend over there, Native Hawaiians are Native Americans when the Democrats control the Senate, and Native Hawaiians are Asian Pacific Islanders when the Republicans control the Senate. One of these socio-political things. It's absolutely true. Some of these groups, by the way, are incredibly heterogeneous. Barack Obama is half white and half African. And data is not available for many, many racial ethnic groups. But using those OMB definitions, these are the trends since 1990. You can see blacks in blue, whites in orange, Native American or American Indian Alaskan Natives in purple, in gray. And then in yellow you have Hispanics, and then Asian Pacific Islanders in blue. Everybody's going down except for Native Americans. Blacks started out higher but are going down faster than any other group. And if you actually notice, there is a white Asian Pacific Islander disparity, for example. But these are the trends in cancer death rates. And by the way, I hate to use survival data as an epidemiologist. I find that 90% of the time I see people use survival data, they use it wrong. But most people know what dead means, so mortality actually is a statistic that people use pretty well. Now let's look at breast cancer. There has been a 39% decline in death rate since 1988 for women in general in the United States. As we look at black women and white women, I want to note there was no disparity in the 1970s. The disparity started in the early 1980s. The black rate actually went high. The white rate started going down, and the disparity between blacks and whites is greater today than any time in our history. And the other three racial ethnic groups are down here below. Now, a couple of things. Ahmadine Jamal, who works with me at the American Cancer Society, has done a number of studies. This has actually been published now. Among women with stage 1 to 2 breast cancer under age 65 diagnosed in the 2000s, the median age was 51 for blacks, 53 for whites. Blacks were more likely to be uninsured or on Medicaid, more likely to have triple-negative cancer. By the way, please note, Oprah makes it sound like all black women have triple-negative breast cancer. It's 35% versus 19%. Blacks are more likely to have larger tumors, more likely to have higher-grade disease. Being stage 2 or 3 versus stage 1, more likely to have stage 2 or 3 disease. Among women with hormone receptor positive disease, a greater proportion of whites receive surgery. Yes, actually in Atlanta, we've published a paper, 7% of black women in Atlanta who are diagnosed with a localized curable breast cancer get no surgery within 2 years of the diagnosis. Radiation, whites are more likely to get radiation versus blacks. Hormone therapy. This is hormone receptor positive disease, yet we have evidence that 21% of the white women diagnosed with ER positive disease don't get treated with hormone therapy. Among women with hormone receptor positive disease, blacks had 105%, 0.1% increased risk of death. The excess risk and death was attributed to insurance differences, tumor characteristics, comorbidities, and treatment differences. Yes, insurance differences are a huge problem. I told you about the 39% decline in death rate since 1988 in the United States as a whole for all women. This is a map of the United States, and the dark blue areas of the country up north, some of them have had as high as a 51% decrease in death rate since 1988. And in purple here, you can see these are the states that have had less than a 30% decrease in the death rate since 1988. That's a disparity. Literally, the death rate in New England has gone down almost twice as much as the death rate in Mississippi. Let's talk about colorectal cancer. There's been a 52% decline in colorectal cancer death rate since 1969, 51% in men since 1980, and 56% in women since 1969. This is the death rate declines for men. And please note the disparity difference in the 1970s for blacks and whites, and the disparity has gotten worse, and the disparity is greater now than it's ever been. This is the rates for Native Americans, Hispanics, and Asian Pacific Islanders. You can see Native Americans have actually had a rise in death rates from colorectal cancer. This is the female figures. Again, there was no disparity in the 1970s. We learned how to screen and treat for this disease in the 1980s, and we have increasing disparities. This is one disease where the disparity, black versus white, is starting to narrow. And then you can see the other three groups that the OMB collects data on. This is a map of the United States, and you can see some areas of the country have had a 63% decline in colorectal cancer death rates since 1980, and some areas of the United States have had a 12% decline. This is a disparity. One of the problems in the United States is a substantial number of people. Now, I can describe them black, white, I can describe them rich, poor, I can describe them Mississippi versus Massachusetts. A substantial proportion of people in the United States get what my lawyers say I have to call less than optimal therapy. This is a paper we first published when I first got to the American Cancer Society. This is one of the few times I'm going to show you survival curves. This is a Kaplan-Meier curve. 0 to 60, that's 5 years, 60 months, 5 years. 0.9 is 90%, 0.7 is 70%. And red is stage 1, blue is stage 2. Red solid is stage 1 privately insured colorectal cancer patients. Red dotted line is stage 1 uninsured, or people who got Medicaid as soon as they got diagnosed with colon cancer. Stage 2 blue solid is insured. Blue dotted is uninsured. The first thing I want you to note is the dotted lines are not on top of the solid lines. That means that if you have stage 1 colorectal cancer, you are much likely to do better if you have insurance versus if you don't have insurance. Insurance matters. If you have stage 2 colorectal cancer, you're much likely to do better with insurance than if you don't have insurance. And yes, ladies and gentlemen, if you're in the United States, you're better off having the more advanced stage 2 colorectal cancer with insurance than stage 1 colorectal cancer without insurance, because the 5-year survival is greater for the people who have the worst cancer with insurance. Insurance matters. This is not black, white, this is American. Lung cancer, we've had a 31% decline in death rate, 45% in men since 1990, and 19% in women since 2002. Part of the reason that the death rate started declining in women later is the peak for women smoking was 35% of adult women smoking in 1965. The peak for men smoking was actually 55% of men smoking in 1955. Actually, if you go to Europe, it was 75% of British men smoked in 1955. But it's 55% of American men in 55, 35% of American adult women in 65, and then we have the declines. If we went all the way out to today, we're at about 15% of men smoking and maybe 13% of women smoking today. Perhaps the greatest cancer control intervention of the 20th century was the intervention to get people to stop smoking cigarettes. And here you can see a map of the United States, and on top, the darker states are the states where smoking prevalences are higher, and on bottom, the darker states are states where lung cancer mortality is higher. And you can see smoking prevalences in Utah and California are now about 10% of adults. I guess when I talk about smoking prevalence in California, I have to stress that that's tobacco smoking, right? The causes of cancer. The key to cancer prevention is understanding its causes. And here we have a Graham-Colditz modified slide. 33% of cancers are due to smoking. 20% are due to overweight and obesity. 16% are due to hereditary factors, and we'll talk more about that in a second. Diet and lack of exercise each account for 5%. By the way, 1 to 1.5% of all cancers in the United States is due to medical radiation. One of the reasons why we worry about this mammography craze among women in their early 40s is when they're 70 years old, that's a hell of a lot of radiation cumulatively that they've gotten. The CT scans that we don't need, like these scans, these heart scans and all of these other things that people are doing to screen for disease, I worry about them as causes of cancer. When we talk about obesity, less than 15% of Americans were obese in the early 1970s. It's over 35% today, and you can see comparing to several of my favorite countries here, and there is a McDonald's effect in many of these countries, even in Korea to an extent. When we look at non-Hispanic black women, the rate, we said 35% for the average woman in the United States. The obesity rate among black women is over 55%. For some Hispanic women, it's even higher than that. Obesity causes cancer. There are also hereditary causes of cancer, and these are some studies that have looked at what are the attributable risks. 28% of stomach cancers, perhaps 15 to 35% of colon cancers, a third of pancreatic cancers, maybe even 20-25% of lung cancers are due to heredity. And of course here, most of us know about BRCA1 and BRCA2. There are a number of other genes and genetic mutations, genetic transpositions and polymorphisms that tend to increase risk of cancer. Here, the relative risk is low here, but these are much more commonly found. These are less commonly found, but the relative risks are high. This is just some of the things we can do in cancer prevention. Some of this is the work of the NSABP, some of it the work of SWOG and others. But when we know that we have breast cancer risk increased, we can treat with PARP inhibitors, some of the chemoprevention work done by some of the people in this room, some of the greatest clinical trials of the latter 20th century. We can increase surveillance. We can do surgical removal of the breast. These are interventions for hereditary cancers that are now standard in cancer prevention. Surgical removal of the stomach even, or colectomy, are things that we sometimes will do. But these are what we can do, and this is how we have advanced cancer prevention through clinical trials. I'm going to end, talked a little bit about how we need to get treatment out into the community and get treatment to everyone. We also need to get prevention out into the community and get prevention to everyone. Remember that 140,000 deaths that we're going to lose this year that would have been preventable if 30 years ago everybody had gotten everything we know people should get. I think, how can we provide adequate high-quality care to include preventative services to populations that so often don't get them? It's one of the most important questions that we can ask in cancer medicine today. Been a huge movement toward equality in this country where everybody gets the same thing. If we're going to move toward health equity, sometimes certain populations are going to need a little bit more than other populations in order to be able to get to the place that we all need to get. And I thank you for your attention.